Hello, everyone. I'm Greg Mackling, co-host of 680 CGOB's morning show, The Start, and welcome to the Health Report 2.0, Leaders in Medicine in conversation with friends of St. Boniface Hospital Foundation. Hope you're having a fantastic start to your day. And before we begin our program, we want to do this and acknowledge that we are gathered on Treaty 1 territory, the traditional lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This year, St. Boniface Hospital is celebrating its 150th birthday. Over its long history, the hospital has been a focus for medical science advancements, a place where trailblazers and innovators make breakthroughs that translate from the bench to patient's bedside. The hospital has consistently ranked as the #1 research hospital for its size in Western Canada, something we're very proud of. Here we have investigators forging ahead toward discoveries that will change the lives of patients for the better, not only here in Manitoba, but around the world. And all this is supported by people like you who have invested in the hospital and its researchers. Thanks to thousands of supporters over the past 50 years, St. Boniface Hospital Foundation has raised over $253 million, fostering innovation, discovery, and of course, compassionate care. We invited you here today specifically on World Alzheimer's Day, and I'm excited to welcome our guest, Dr. Benedict Albensi. He's Principal Investigator and Everett Endowment Fund Chair at St. Boniface Hospital Research Center. Dr. Albensi is a leader in his field, driving investigation to understand the mechanisms of dementia, Alzheimer's disease, brain injury, mitochondrial dysfunction, memory, and aging. Until very recently, Dr. Albensi was based at St. Boniface Hospital Research Center. He joins us today from Fort Lauderdale, Florida, as the newly appointed department chair for Pharmaceutical Sciences at NOVA, Southeastern University College of Pharmacy. Did I get that all right, Ben?
You did. How are you,
Good
Greg?
to see you, Dr. Albensi. He's going to stay busy as he's also maintaining his lab here in Winnipeg at St. Boniface Hospital Research Center. We'll be talking today about the exciting and ongoing research he and his team are doing. So always looking to bring scientific discovery to new heights. Dr. Albensi is a defender of people with dementia, the elderly, people with cognitive disorders, and those from disadvantaged educational backgrounds, promoting cognitive and mental health equity. And I'm eager, as always, to chat with Dr. Albensi. But before we get things rolling, just a few quick housekeeping items. Dr. Albensi and I will chit-chat for about a half an hour. Then we'll have about 15 minutes or so for you to ask your questions through the chat box. I'm sure you can see that on your screen. We're going to actually take the questions in your question and answer box today. So that's just a change from the last time you gathered with us. And before we wrap for the afternoon, we're going to do something special and share a 3-minute thesis, 3MT presentation from one of the talented graduate students training at the hospital's Albertson Research Center. I think I've got that all out. I think I've got it all straight. So now, without further ado, please join me in welcoming Dr. Benedict Albensi. So Dr. Albensi, we visited on radio yesterday morning, and full disclosure, you and I become friends over the years. So we were texting and emailing over the weekend in anticipation of our conversation yesterday and today. How are things going in Florida, and how are you settling into your new role? How's the family doing with the big move?
Yeah, so very interesting, a big move for us. But I wanted to thank you for that kind introduction. It's so great to be here. And of course, I'm very excited about my new position. But, you know, it really comes with a bittersweet sort of emotional aspect because I have so many friends in Winnipeg. I was there for 16 years. My daughter Speranza is still there at the University of Manitoba, starting her second year. So it's a big change for us. But I'm also so very fortunate to be at St. Boniface for the last 16 years and to get the great support from the hospital, the research center, and the foundation. So thank you so much for that. I mean, it was just a tremendous place to work. And I was really so honored to be there, to be #1 in Western Canada and the top 5 or so over the years for research intensive hospitals. So it was just a great opportunity. So thank you for so much for having me, Winnipeg.
Well, you've always been so kind and generous with your time and giving us a look behind the scenes as to how your research works and where it's going. And so with that in mind, I don't know if I've ever asked you this before. Maybe it's been some time, but for those that are meeting you for the first time today, how did you become first interested in neurodegenerative disorders, research, and specifically diseases like Alzheimer's disease and dementia?
Yeah, so it really started a long time ago. It really started as a kid. So I was interested in science and astronomy, cell biology and electronics. And I was one of those geeky kids that would make radios and do that kind of stuff. And I'd read books about circuits and cell biology, all the parts of the cell. And that was really some of my early interest in science. And then as I got older, I really developed a more specific interest in intelligence and how the mind works and the brain and memory and different aspects. And so I went to school and I got my PhD in neuroscience. In fact, my bachelor's degree was in general science because they didn't have any programs yet in neuroscience. So I had to kind of put together 3 different majors. I took courses in biology, psychology, and some physics, and really kind of developed my own program. But then I did get my PhD in neuroscience. And so my early interests, though, were really focused on intelligence and memory. But before I came to St. Boniface, I worked on models of head trauma and stroke. And so I worked on brain injury, and I also did a little work with epilepsy, and all that was really good. But really, when I came to St. Boniface, I shifted my focus to memory impairment and Alzheimer's disease. And so that's kind of how all that came about. And I love what I do. I mean, I love understanding how memory works, but it's also important for me to think about memory impairments. And that's a huge part of what we do in my lab with regards to dementia and Alzheimer's disease.
I always love how you researchers, you medical researchers have these great analogies for things, how different systems within the body work. And as you're talking about, taking apart radios and building radios and doing different things, how similar might a radio be and how radio waves work and interact with different pieces of equipment, be the brain and the way it interacts with our bodies and allows us to do the incredible things that our brains allow us to do, Dr. Albensi?
Well, it was really a great primer because when I studied these books on electronic circuits, it really set the stage for my more specific training. So I got a PhD in neuroscience, but I got specifically trained in electrophysiology and an MRI, so a type of neuroimaging. And so having that basis in electronics and circuitry really helped me to understand circuits in the brain and also other aspects of electronics and imaging associated with medical imaging. So it really primed me well. I didn't really plan it that way, but it all turned out well, I think.
I think that's quite often the case. The things that we don't necessarily plan end up being our final destination. So if the journey's right, not to get too philosophical, I think you end up where you're intended to. And so when we talk about your 16 years, clearly the scope and scale of Alzheimer's disease and the research around it has evolved over the last 25 years. How so?
Yeah, it's amazing the changes that's occurred, especially if you think just about Alzheimer's disease. I mean, it was 20, 30 years ago, I think in the 80s, where scientists first discovered amyloid beta. That's that sticky toxic protein a lot of people talk about, and the drug companies are targeting to either try to clear it or block it. And around that same time, just a year or two later, I think around 1986, there was the discovery of tau being yet another pathological marker. And so it's biochemical alterations in these two proteins people had suspected was really the causative agent of Alzheimer's, but we didn't know that then, and we still don't even know that now. So right now, we still believe, and the theory is that these are associations. And so we don't know for sure if they're causative agents. But, 20 years ago or so, there was heated controversy, and people belonged to one camp or the other. You either believed in the amyloid beta theory or you believed in the tau theory. And so now I think there's been an integration of these theories, but even so, we're moving even away from tau and also our amyloid beta to some degree. And there's a lot of new ideas out there. As you might know, my lab focuses on yet another view, and that's bioenergetics and brain metabolism. And more specifically, how mitochondrial dysfunction might actually be a causative agent, not just in Alzheimer's, but really a central player in cancer, in diabetes, so many different age-related diseases, and even the primary mitochondrial disorders. So I really jumped into that arena about 8 years ago, looking at that as a process and as a mechanism for perhaps what's the causative agent for Alzheimer's. So a lot of changes. Of course, we have a database. We had ADNI, which is the Alzheimer's Disease Initiative, which involved neuroimaging in the US and Canada. About 4 years ago, funding increased dramatically in the US. President Obama, about 10 years ago, signed what was it called? The National Alzheimer's Disease Project Act, where it actually became a law that Congress had to review progress in Alzheimer's disease every year. And so a lot of things have changed. However, if you look at diseases, age-related diseases like cancer and heart disease, we've made great progress. And really, to be honest, Greg, we're failing miserably yet with Alzheimer's disease, because if anything, the rates keep going up. And it's still the 6th leading cause of death. And so we haven't had any improvement. We've only have about 5 drugs over the last 10 years or so. The first drug, I think, was approved in 2003. And only very recently has there been a new drug approved. That was just a few weeks ago, really. And that has very specific limitations. You have to have an IV, and it's only every other month. And I believe your general practitioner has to refer you to a specialist in order to receive that prescription. So, we're not there yet. And so there's lots of room for improvement in Alzheimer's disease research and care.
You mentioned the fact that these two camps have come together now in that basic understanding of maybe where to start all these years later. It just reminds me of the conversations we've had over the years about silos and research taking place in silos, and maybe give us an understanding based on several of the interesting studies underway at St. Boniface. Of course, we know about Dr. Grant Pierce's study with regard to ground flax and its impact on blood pressure and heart health. Now all of a sudden you're talking about perhaps flaxseed and the effects of it on memory and cognition. That seems fascinating to me, that we could be finding a combination, another use for something that we know is working so well in another part of the body on another system.
Yeah, so of course, Dr. Grant Pierce is really a leader throughout the whole world for his work with flaxseed and its benefit for heart health. And because of that, St. Boniface Research Center has really taken a lead throughout the whole world for that sort of work. And I saw some of the work that Dr. Pierce produced over the years, and it's made me think, well, why aren't we looking at it in a context of brain health and memory? And so I did some research, and I found there was very, very little known about the effects of flaxseed in brain development, and especially memory and Alzheimer's disease. And in fact, there was no clinical trial that had been conducted previously. So I talked to Grant, and it made sense. And he was very supportive of me submitting a grant application. And to make a long story short, I did get some funding. It didn't fund the study completely. We're still looking for funding for our flaxseed trial, but we got all our approvals. Health Canada approved the project, and then COVID hit, right? So our trial's been on hold for about 1.5 years, and only 2 weeks ago was it approved to restart. So we're all ready to go. So the flaxseed story is a very interesting story. I think we're really the first clinical trial in the world to test a flax beverage in those with suspected Alzheimer's disease. And we've got a lot of people that are interested. I think we had 500 people call so far. But pretty much, the bottom line here is that the flaxseed, of course, contains omega-3 fatty acids, and there's a couple fatty acids in flax, just like in fish, that we believe might have benefit for memory, also have benefit at reducing inflammation, and really hoping to reduce those pathological markers of Alzheimer's disease. So I'm very excited to get started on that trial in Winnipeg, and I'm hoping that we're going to get some great results, or we're going to be able to have that trial here in Florida also, and at other sites. So that's one of the things I love about St. Boniface, is that they're open to me continuing my work there. And so I have collaborations with a couple other investigators. I'm hoping to also test creatine in a clinical trial in Winnipeg and here, to have a multi-site trial going forward with other collaborators at St. Boniface. So I'm very excited about the flaxseed trial, and let's hope for the best going forward.
Collaboration, another word that comes up quite a bit, and the sharing of information between research labs, not only within the research center itself, but across international borders and around the world. And one of our viewers today says and wants to know if it's been looked at, the relationship to deafness, arthritis, and Parkinson's. Is there any relationship there with dementia or Alzheimer's, Dr. Albensi?
Well, absolutely. And so dementia, we see dementia and Parkinson's disease. We see dementia, Alzheimer's is only one type of dementia. It's the most common form of dementia, but we do see dementia associated with other diseases as well. So this is certainly true. Mixed dementia is probably the second leading type, and vascular dementia. So mixed dementia could be a variety of things. So there are other forms. I think the Alzheimer's type is probably close to 70% of all the different types of dementia.
So what about some other ongoing projects, or one in particular in your lab? Tell us about your investigation with regard to gender-based differences associated with Alzheimer's.
Well, as you may or may not know, clinical trials over the years really neglected to look at women, and not just the clinical trials, also the animal studies. Only recently have we seen a change in this behavior. So I'm not going to try to take credit for where credit is not due, but about 4 or 5 years ago, we obtained some results in our animals and our transgenic mice, and we found sex differences. We weren't looking for those, but we saw clear and obvious differences in sex in the development and the onset of mitochondrial dysfunction. And this seems to be consistent with women. And of course, women are at greater risk for Alzheimer's post-menopause. Before menopause, the risk is lower, but after menopause, the risk probably triples. So about 2/3 of those that get Alzheimer's disease are women. And so all this started making more sense to me. So we did make those initial observations 4 or 5 years ago. We've published a couple papers now showing clear-cut differences in sex between our transgenic mice, and we believe that we're onto something. So we're very excited about that work. We see not only the onset is different as compared to males, but we see that there's some regional differences, and we see other differences too, besides mitochondrial, there's several different mitochondrial parameters that we look at. So there's a whole battery of tests that we do to look at how the mitochondria does get impaired and how it's different in males versus females. But we also see differences in the deposition of amyloid, that one toxic protein that I mentioned a few minutes ago. So very exciting data that's being generated from our lab in Winnipeg.
Some people might be tempted to simplify it and suggest, well, that's just because women live longer than men. That's why the more cases. That's not the case. There are some actual differences within the body. Yes.
It seems to be the case. I mean, we don't know for sure, but I think it's just too simplistic to think that because women live longer, that's the reason. I don't think that's the case, really. And so there are other aspects. There's hormonal signaling, there's genetics, and even the genetics of the mitochondria have come into play. I don't know if you realize this, but if you look at the genetics of mitochondria, specifically, not nuclear DNA, but mitochondrial DNA, we actually inherit all those from our mothers. And so it's a maternal lineage that's handed down from generation to generation that plays a role in some of these disorders, primary mitochondrial disorders, and who knows, perhaps even in Alzheimer's disease. So there's a combination of things that come into play with regards to sex differences, I believe.
So what's next on the horizon for things at the St. Boniface lab? You've been looking into the effects of leukemia drugs on dementia. Tell us a little bit more of that, if you'd be so kind.
Yeah, so I have an active collaboration with Dr. Scott Turner at Georgetown University in Washington, D.C. I was actually a postdoc there many years ago, and I met Scott when I was at Pfizer in Michigan. So we had a lot to talk about. But to make a long story short, Scott and his colleagues, his team at Georgetown, showed that this drug called nilotinib, which is, like you say, an anti-leukemia agent, was effective at and showed benefit in patients with Parkinson's disease and Lewy body dementia. And so this made major headlines. It was in the Wall Street Journal and was in a variety of different newspapers. And Scott and I talked at these Alzheimer's meetings that we go to and we see each other at. Well, what's going on here? Why does this work? And I suggested to him, and he had the same idea, is that perhaps it's the mitochondria. Perhaps there's something going on in the mitochondria. My lab was already equipped to study mitochondria. And so it seemed like the perfect collaboration. So Scott, he's an MD, PhD. He's doing just primarily clinical trials, and we're doing some of the animal work in my lab in Winnipeg right now, and we're going to continue some of that work here. So we believe that nilotinib, and again, we don't know, but we believe that the mechanism by which it works in dementia is that it might be triggering these cleanup mechanisms. So there are different cleanup mechanisms, maintenance mechanisms in the mitochondria. The scientific word is mitophagy. And cells have another type of process too. It's called autophagy. But really, it's just like throwing out your garbage and using your recycle. So the mitochondria is always trying to improve the quality control, at least until we get older, and then things start to change. But there are mechanisms for cleanup and maintenance, and we believe that this drug is actually stimulating some of those mechanisms. So that's some of the work we're doing, is to figure out how it works, why it works, what's the proper dose, how we can do this in Alzheimer's. Scott's got a current clinical trial on Alzheimer's with this drug at Georgetown, and there's lots of questions to be asked. I mean, one clinical trial doesn't solve or answer all the questions. So I'm hoping to do my own trial here. We have a new hospital here at Nova. So, and perhaps the possibility exists we can do, again, a multi-site clinical trial in Winnipeg and at my new school here. So very excited about that project as well.
So like a lot of things is the key here. I want my elbows and my knee and my back to do the things they do well for as long as possible. Is that what we're trying to do here, is to make the mitochondria do the things they do well for as long as possible, free it up from seizing up, so to speak?
Well, we talk about Alzheimer's disease. Of course, that's what I focus on, but there's a bigger picture actually to be realized. And what I'm talking about are the hallmarks of aging. And Professor Sinclair at Harvard is well known for his work on mechanisms of aging. 20 years ago, nobody listened to him because everyone just thought aging is a normal process. But he's trying to convince people that no, we don't have to accept 80 years old as our endpoint. The longevity could be extended. And so, a lot of people find some of what he talks about controversial. But what if the possibility exists that we can extend lifespan to 120? So that's really the premise. And so if we can do that, well, how do we do that? Well, we examine the hallmarks of aging. And so there's about 9 hallmarks, and I can talk at length about these, but one of those hallmarks is mitochondrial function. So it's one of those things, if we can improve how the mitochondrial work, then perhaps we can extend lifespan and also improve the quality of life and prevent disease. So the other aspect to this, of course, is that mitochondria are central, and I think I hinted at this a few minutes ago, to not just Alzheimer's, but also cancer, diabetes, aging. The list is like endless, 20, 30 different diseases and conditions where the mitochondria play a central role. So again, it's not only related to disease, but really a hallmark of aging. And if we can control these hallmarks of aging, we can improve the quality of life and extend lifespan.
Absolutely fascinating. We're getting some tremendous questions here, and I'm going to jump over to the questions from our viewers today right now, just because it ties in with this idea of slowing down the aging process. Jessica says, I work in a personal care home and I'm noticing a connection between education level and dementia. Is there a clear link between education and development of cognitive illness?
Well, there's certainly a clear link between mental activity and dementia, but whether or not it has to be based on education or not is still kind of being examined. I mean, perhaps you have this sort of job where it only requires a grammar school or bachelor's degree and you don't have an advanced degree. I mean, you could have, but it requires a lot of mental effort. So the mental effort probably is more important, and the clinical evidence seems to be very supportive of that as opposed to just direct education. But there is a correlation between the number of years you've attended school and the risk for dementia. But I'm not sure if it's education by itself, given the studies I've seen.
How about this? What is the relationship between diabetes and dementia, Alzheimer's, and what is the best form of prevention? We talk about prevention, Dr. Albensi. If we can prevent people from getting here, having to solve it or cure it is it's off the table at that point.
That's a great question. And in fact, in the lab next to me, Dr. Paul Ferniho studies diabetes, and he's a collaborator in some of my projects and a co-author. And so there's certainly an overlap there that's very significant. In fact, some investigators years ago considered Alzheimer's to be type 3 diabetes. You probably have heard these terms before, type 1 and type 2. Well, some people went as far as saying that Alzheimer's might be type 3. And I think there's some truth to that. And in fact, that brings up a good point, is that I think going forward, what we're going to learn is that Alzheimer's can be divided into several forms, just like cancer. You know, when we understood cancer many years ago, we just kind of lumped it all together. But then as science progressed, we started itemizing it more and treating cancer differently. We're not quite there yet with Alzheimer's disease. I think we have to define different types of Alzheimer's disease more carefully. And so I think there's certainly the rationale and evidence that shows that metabolic disorders like diabetes could be one type of Alzheimer's disease. So I think that's an important point. Good question. It's very interesting to look at drugs like metformin. So if you follow this, I see people talk about this drug at the aging meetings I go to, not the Alzheimer's meetings, but the aging meetings. And so it's a drug used for diabetes. And so some people are using this that it might reduce the risk for dementia, but also using it off-label just to slow down aging. So it's a bit controversial. But yeah, there's a lot of evidence to show an overlap between diabetes and Alzheimer's.
So if we can predict as well as prevent, that would be something else. One of our viewers wants to know, is there perhaps in development, or could there ever be a blood test for early detection of dementia and Alzheimer's? Because I think I've learned from you that the only real way to know if anyone has Alzheimer's is in the past tense, post-mortem, correct? Or are we moving past that now?
We kind of have moved past that, but it's very recent. I think it was only at the Alzheimer's meeting I went to a year and a half ago, where there were several studies all presented at the same time that showed very high accuracy and predictability with blood tests for Alzheimer's. So we're right at the beginning of trying to incorporate a blood test into a standard of care, a standard diagnostic procedure. I'm not sure. I think that's going to be regionally dependent, but I think the evidence is there to suggest that we can start using some of these blood tests in addition to what you described with the autopsy. But when we talked a few years ago, yes, that was the case. So only recently have the blood tests seem to be have gotten better, and there's the studies have been published showing that certain blood tests might be accurate enough to use that as a standard of care.
The more discoveries on every level just has to give you confidence in what you're doing and that you're going down the right path. That you might not be confirming the big picture stuff, but every step along the way, does it encourage you and does it inspire you to keep going?
Well, you know, I mean, I think you have to be in this kind of job because you love science. That's the first thing. And so just being in the scientific community is enjoyable for me. But my mom developed dementia several years ago, and she died of it in 2017. And so that kind of changed my whole perspective. Now I feel like we're never doing enough. Like, why wasn't there a drug that was effective? Why didn't my mom get better care at the rest home? You know, now I look at things from a patient's perspective. I look at things from the caregiver's perspective. It really changed everything because there's a whole nother part to this whole story that affects society. And so, you know, at Pfizer, when I worked at Pfizer, we used to say the patient is waiting. And so how true is that in Alzheimer's? And so we need to develop more effective therapies. Some of it's going to come from drugs, but there's a lot of novel stuff on the horizon right now. My lab's involved in some of it. We talked a bit about it on the radio yesterday: electrical stimulation, magnetic stimulation, stem cell therapy. Also, like I said, mitochondrial dysfunction and mitochondrial-based therapies, lots of new stuff. So that's exciting by itself. But I have a new appreciation for what's important and what needs to be done right away so that we just don't keep losing our loved ones the way we do.
So blood test, something that's looking to be very promising. What about predisposition? What about our genetics? Is there any proof that we are predisposed potentially to developing Alzheimer's?
Yeah, so one of the first studies I have to tell you, today is World Alzheimer's Day, right? And so on LinkedIn, if you follow me on LinkedIn, I posted some milestones. And so there's a link to the Alzheimer's Association website. So I'm just looking at my cheat sheet here. So it was in so the first genetic study of Alzheimer's was in 2003. And then shortly after that, some people published some evidence on ApoE, a risk factor, genetic risk factor for Alzheimer's. Genetics certainly play a role. A lot of the evidence in the studies right now suggests maybe 8 to 10% is related to this. Those numbers might go up as more studies are published and we learn more. There's certainly hundreds of genes that scientists are studying, but in terms of the actual genes with the very strong evidence, we're talking about 4 or 5. But I think that number of 8 to 10% will go up as we learn more about the role of genetics. Dr. Rudy Tanzi at Harvard, of course, is well known for his work with genetics and Alzheimer's, and I refer you to him, his work, to learn more about that.
So what about presentation? You mentioned the difference between the risk factors and the rate of incidence of Alzheimer's between men and women. What about the presentation in terms of Alzheimer's with regard to how it presents? And I apologize, I got to going on the flow here, or on the fly with Jennifer's question. But is there a difference, much like women's heart health? We know there are differences in the way women present when they have on the verge of heart attack or heart failure. Is there a difference in presentation? Long way around. Sorry about that.
Yeah, there is. But you know, Alzheimer's is not a disease that starts overnight. So we see some of these signs and symptoms appearing gradually. And sometimes they're missed, especially if you're not with a person every day. If you don't know them well, you might be missing some of those signs and symptoms. So the casual observer, someone you meet just at dinner and you don't know them very well, you might not realize that their everyday life is being affected. So, you know, if you go to the Alzheimer's Society's website, they talk about some of these things, and it's really good to pay attention to that. In the US, we call it the Alzheimer's Association. These organizations are really, really good at transmitting this information to the public. And so I would encourage you to go to one of those websites to learn more. So for example, if you forget your keys, is that a sign of Alzheimer's? Well, not really. I mean, you know, anybody could be doing that. But if you put your underwear in the refrigerator, then I would suspect that's something that you might want to look into more seriously. Okay. And so it's those sorts of unusual behaviors. My mom used to start hoarding food in one of her dressers, which was very strange when we first discovered it. In a clothes dresser, she started putting food, and the rationale for that wasn't clear to me. But, you know, these are some of the behaviors that we've seen.
And so often in retrospect, we realize now what that was.
Right. That's
so,
right.
that's the benefit of looking back. And one of our viewers, David, says, if you could look back 10 years, what treatment or prevention coming out of research is proven positive today and is still used, whether it's Alzheimer's, dementia, or other that you might want to tout, Dr. Albensi?
So I can't overemphasize the importance of exercise and diet. And in fact, it's true for cancer. It's also true for Alzheimer's disease. We can reduce our risk probably by 50% with enhanced nutrition and exercise. And I would argue that exercise is a little bit more important than nutrition. Now, the problem is that if you don't get started early enough in life, starting your exercise program, if you've been sedentary all your life, you've been a couch potato for 30, 40, 50 years, and then you start an exercise program in your 70s, you probably won't get any benefit for your brain, although there's tremendous benefit, of course, with exercising for heart health, general physiological functioning. But to reverse that Alzheimer's process, if you haven't exercised earlier, well, that's probably not going to help. But exercise and diet, tremendously important. Try to reduce your risk for head injury. So, if your kids are in sports and that sort of thing, try to get them to wear their helmet if they had a mild concussion. Over the years, we used to only think that severe head trauma was important. And we've learned the hard way, so to speak, that mild TBI, especially repeated mild TBIs, probably can increase your risk as well. So of course, in any family, you're going to have kids active in sports and soccer and hockey or football. And so pay attention to that.
You and I have discussed the fact that about 20 years ago now, I suffered a frontal lobe brain injury, and I still struggle, especially when I'm tired. Just a few moments ago, I was struggling to look for the word symptom, and I couldn't quite find it. I'm on about 3 hours sleep tonight, not an excuse, a reason that sometimes I know, in combination with what my brain's been through and that lack of either sleep and or exercise, I'm struggling in my cognitive abilities. And so I think it's critical that people don't ignore those things.
Right. Well, you mentioned a very good point, sleep. I think we often forget about the importance of sleep. And, it's during sleep that memories are consolidated, right? Many of us think that sleep is a rest period, and it kind of is. But the brain, we've learned over the years that the brain is actually very metabolically active. And there's a whole series of sleep-wake cycles and RAM and REM sleep, lots of stuff going on in sleep. Memory consolidation occurs in sleep. And we actually clear out that A beta clearance occurs during sleep. So sleep's another very important factor for reducing your risk.
We always talk about the value of donor dollars, and one of your good friends and colleagues, Dr. Gordon Glazner, tells a story. He tells a lot of great stories, but he talks about how when he was recruited to come to Winnipeg, and he was at Safeway buying some groceries on an extended stay, and he realized that the people he was rubbing shoulders with were the people that were funding potentially the research that he was going to come here to do. So in that spirit, I've got a message here from someone who describes themselves as a middle-aged donor. What can I hope and expect for progress in terms of treatment over my expected lifetime? And will my dollars make a difference?
Well, I think every dollar makes a difference because most of us have only so much we can contribute. But if everybody contributes a little bit, it makes a huge difference. I mean, there's always the Bill Gates, the Bezos, those sorts of people in the world that can donate millions and millions and create programs. But we only have so many of those in the world, right? So I think it is important for individuals to contribute as much as they can because it makes a huge difference. In the US, we have 330 million people. In Canada, we have about 35 million people. And if everyone gave $1, think about the amount of money that could be raised to support research, Alzheimer's research, and care.
One last one here before we wrap things up. Jessica had asked a question earlier, and I maybe didn't ask it exactly the way she wanted me to. So Jessica, accept my apology for that. But I think I know the answer, but just for clarification, does neuroplasticity aid in the prevention of dementia, or is dementia purely an aging illness? And I think we've answered that second part, but that first part, maybe we could go into that a little bit.
Yes. So, I mean, I spent years studying synaptic plasticity as a driving mechanism for memory. So, but the point I neglected to make is that not only do we go through this process of plasticity all the time, but I think we've underappreciated the plasticity that can occur after brain injury. So I'm talking about head trauma, and there's several good books out there. I think the one's called How the Brain Changes Itself. And there's several good books that have been published over the years. I want to write my own one of these days about the plasticity and the regeneration that's possible in the brain after a head injury or after a stroke. And we don't emphasize that as much, or we don't think about how to initiate programs and brain rehabilitation as often as I think we should. And I think it has tremendous potential. We can exploit this a lot more at those at risk or those that have had prior injuries. And just doing it in general, like you're suggesting, to reduce our risk. So yes, plasticity and enhancing ways to improve our memories, I think it is all beneficial. Now, on the other hand, I mean, there are a lot of scams out there, and we have to be careful. We have to be choosy. We have to be a critical thinker when we evaluate which brain fitness program is out there, because there are a lot of people out there that don't have clinical evidence to support the claims for their particular program, and that's a problem.
So let's wrap it up then on allies and advocates. How important is it that if our parents, our siblings, someone we know and love seems to be going, down this path, that we become an ally, that we become an advocate, and sort of help them through and down this path, because it's got to be, and pardon the language, it's got to be hell for the person on the other side, especially if they realize what's happening to them.
Well, being a caregiver is stressful, and it actually increases your risk for dementia, just being a caregiver to someone else with dementia. In fact, my aunt and uncle both had Alzheimer's, but my uncle got Alzheimer's first. And I'm guessing in part, this is an N of one, but he developed Alzheimer's, and then she was his caregiver, and she developed Alzheimer's later on. So there is evidence showing that caretakers are also at increased risk for dementia, given the stress involved. I mean, someone might have Alzheimer's for 10 years. And if you're the only caretaker, I mean, think of all the energy and support that's involved in that sort of scenario.
Always a privilege to spend some time with you, Dr. Albensi. Anything you wanted to get out today that I didn't ask you about, or can we wrap things there?
Well, I'm happy to answer other questions. Just send your questions to the St. Boniface Foundation. I'm happy to follow up on any questions, and just nice seeing you, Greg. Hello to Winnipeg. Like I said, very bittersweet moving here. So lots of fond memories for Winnipeg and the foundation and St. Boniface. So thank you for having me today. It's certainly been my pleasure.
Thank you, Dr. Albensi. All the best to Lisa and all the girls in your family. We miss you already, and we appreciate everything you've done to help put Winnipeg on the map in terms of your research and your ability to share and to bring the conversation down to a consumable level like we've done today. You're a special person, and we appreciate you very much.
Okay, thank you, Greg. Okay, take care. Okay, bye-bye.
Our pleasure. So before we wrap up today, we're excited to share the People's Choice winning 3MT presentation by Dana Al-Hattab. The 3-minute thesis program. I've been honored to be a part of the selection process of this, and it's incredible. I call it kind of the elevator pitch of some of the most complicated stuff you can imagine. It's an annual competition for graduate students in a thesis-based program. So it's basically what they're trying to do is to boil down what they've been studying into a 3-minute presentation. And Dana is using a mouse model of high blood pressure to identify the role of protein scleraxis in hardening blood vessels, and to investigate how deleting scleraxis enables vessels to become healthier. Dana studies heart and vascular disease so that someday she can help develop better therapeutic approaches for patients. With a bachelor's degree in dentistry, She has volunteered by supervising students in the U of M Pediatric Dental Clinic and participated in the Youth Biolab Meet a Scientist program, talking about science with high school students. She represented St. Boniface Hospital Research in a field of 12 provincial finalists at April's 3M competition. We invite you to enjoy Dana's presentation right now.
Cardiovascular diseases kill about 18 million people every year. They are the leading cause of death worldwide in both men and women. Patients with cardiovascular diseases usually die from heart attack, stroke, heart failure, or even kidney failure, similar to this gentleman in the picture who has high blood pressure. Most of these diseases are related to vascular dysfunction, or what we call vascular stiffness. More scientific term, vascular fibrosis. So normally, our blood vessels would act as a mini pump or as a balloon. When they are filled with blood, they would expand. And then they would contract to push the blood forward to other organs. However, this is not the case if you got a stiff vessel. In stiff vessels, it's really hard for it to relax or contract normally. And this is because of the protein buildup on the vessel wall that would act as a mesh-like and will make the vessel wall more thick that would impair the blood flow going to the organs that need it. The protein buildup is represented similar to the bricks buildup on the wall, which make it more stiff. In a similar process, we found that there is an important protein called scleraxis that would trigger the protein buildup in the heart, making the heart more stiff. In a medical condition, we call it cardiac fibrosis. So now my project is to see the role of scleraxis in the protein buildup or in the stiffness of the blood vessels. If we imagine that the protein buildup is similar to the bricks on the wall, and the scleraxis is the cement that is holding them together and helping them build up to become more stiff. Having a mouse model with high blood pressure and stiff vessels, if I genetically target the scleraxis or the cement from these stiff vessels, are we able to restore the function of these unhealthy stiff vessels to healthier ones? Are we able to target the scleraxis in the drug design for patients with high blood pressure? Are we able to rescue this gentleman in the picture and millions of others who die regularly from vascular-related diseases? All of these questions I'm aiming to answer throughout my project. Thank you.
How about that? Fantastic work, Dana. We really appreciate you sharing that with us. And once again, congratulations for your participation in the 3MT competition. It's absolutely incredible work by everyone involved. Now, before we close today's event, I want to let you know that we do have one more session of the Health Report 2.0 scheduled for this calendar year. It's coming up this fall, Tuesday, November 30th. You won't want to miss this. Dr. Davinder Jassal, Principal Investigator in the Institute of Cardiovascular Sciences, will join us for our final session, as I mentioned, of 2021. Happy World Alzheimer's Day. Tomorrow is the first day of fall. Thank you for your time. We appreciate you joining us. And thank you again to Dr. Benedict Albensi for sharing his expertise. And a thank you to our friends here at Bounce Design for producing today's event. We'll see you next time. Have a wonderful day.